I think treating lupus nephritis is very much like the blind men and the elephant, because what we have is a heterogeneous disease, and we have heterogeneous pathology, and it overlaps like a spectrum of events, which is very convoluted. So we think we get a handle on, oh, this might be very intriguing for nephritis, but then we test it on everybody, regardless of what's going on inside the kidney, and we often get very convoluted results. So I think one thing we have learned, and of course, we do now have 2 approved drugs for lupus nephritis. One thing we've learned over the years is that one drug does not fit all. And I think this resonates very much with the conversations that were being had earlier today for rheumatoid arthritis. We're all intrigued by the idea of biomarkers. The field is clearly, to get to precision medicine, extremely complex. We do have better tools. We're beginning to approach it. We're beginning to drill down. But we're going to need to get to a point sooner or later where we can go drug by drug by drug and find the subset of patients in advance who might be more likely to respond, perhaps even find ways to guide dosing using changes in some of these markers. And it's going to take a long time and it's going to be hard, but we do have the tools. These are my disclosures. And here's some literature that you can read in case you went out and had a snack and are about to fall asleep. If you just read these papers, you don't have to listen to the lecture. So we don't really have an algorithm for treating lupus nephritis. We have some guidelines. Right now, we still are working with about a 10-year-old set of guidelines from the ACR, led by Beverhan. And it essentially boils down to, it doesn't matter whether you start with MMF or cyclophosphamide, either one would be about equal. Again, if you look at the whole range of lupus patients, you're going to get about the same % response. If one of them doesn't work, you should switch to the other. That's the guideline. And then if that doesn't work, you could consider Rituximab or calcineurin inhibitors, none of which really have grade A evidence until this year. But that was the set of guidelines. We do have a set of guidelines from EULAR that's much more recent, but unfortunately, they didn't really make much of an advance over this. And a lot of the things that are particularly interesting in the field right now, such as urinary markers, are just not quite mature enough to help us in advancing the field and advancing clinical practice. But we're sort of wistfully looking at them because they're coming in, and we don't have them in guidelines yet because you can't get in a guideline unless you're really validated. So this is where we are. MMF or cyclophosphamide is how we start. And there's a pretty good evidence base for that, predominantly from the ALMS trial, but not only from the ALMS trial, which was an induction trial of 370 patients, and you got almost the same % response if you used MMF or IV cyclophosphamide. Now let's look at the criteria for response here. The criteria was a decrease in urine protein to creatinine ratio. If you were nephrotic, you had to get subnephrotic range. Or if you started out subnephrotic, you had to decrease the proteinuria by 50%. And you had to have stable serum creatinine, or you could have improvement in serum creatinine. And that was a pretty simple endpoint. But I would suggest to you it was also not a very stringent endpoint. So not much was required to meet this endpoint other than getting better. But you didn't have to get all the way better. So I would like to point out to you the most important finding from this trial, and that is that only a little more than 50% of the patients in either group met this criteria. And that's not okay. It's not okay because we know if you don't improve in the first 6 months, it has a big impact on prognosis. So these 2 equally recommended first-line therapies are clearly not good enough. So I'm going to ask you a question. Oops. A patient with lupus nephritis, given 2 effective treatments, is likely to do better than if given only 1 effective treatment. True or false? Or maybe. In other words, if our currently recommended first-line treatments are not good enough, would it help to add an extra effective treatment? True or false? And should we be doing that? Or is it maybe? Am I supposed to sing or dance now? Oh, okay. You wouldn't want that. Okay, that's enough time, right? All right, so most people say true, some people say maybe, and very few people say false. That's correct. It's either true or maybe. So there is justification for combination treatments in lupus nephritis. I like this one. There are quite a few of them now, but I like this one. This was a real-world study. It wouldn't make it to the FDA for any kind of approval of anything, but it was basically a study of cyclophosphamide with glucocorticoids, which is a pretty standard regimen, versus cyclophosphamide plus. And cyclophosphamide plus could be any choice of all kinds of different things. It included hydroxychloroquine, and you could pick mycophenolate or azathioprine or leflunomide, and none of which are approved for use in lupus nephritis, but you could do that. And so it turned out that it made a big difference if you added something on and did a double therapy. And it didn't, all these different ones were tried, you could do any of them, and you did a lot better if you got in that group that got the extra therapy. So complete remission was found in 21% of those on cyclophosphamide alone, and in 39.5% of those with cyclophosphamide plus. All responses went up to almost 90% in the cyclophosphamide plus, something we don't see. And fewer treatment failures, obviously, and the SAEs, the serious adverse events from adding this extra therapy, was probably about the same. So that's pretty good evidence base. But if you think about it, every single clinical trial we have is based on the premise that you start with something on the baseline and you add something. Because in lupus nephritis, we can't have a placebo group. I would argue to you that in non-nephritis trials, we could have a placebo group, but not in lupus nephritis. They really are too sick. And so all clinical trials are based on this premise, and I'm going to get at the end mentioning that we have 2 drugs now approved for lupus. They were add-on therapies. But is it that those drugs are so special, or is it that we need to use more than one therapy for lupus nephritis? And I would suggest to you we don't know the answer to that. So the answer to the should you use another effective drug would probably be yes, but which drug? I don't know. That's a maybe. I want to talk to you about a case of an anxious college student at the time of her exams. This was a real patient of mine. And she presented with fatigue and anxiety. She had pain in her hands in the morning, but she pointed out that she just completed a very large typing project. She thought that was responsible. And then, she said, oh yeah, and I have some swelling in my legs. And so it turned out that she had 3+ protein in her dipstick, and her protein to creatinine ratio was 3,400 milligrams per gram, roughly equivalent to nephrotic range proteinuria. And she had anti-DNA positive and low C3, and a positive anti-Rho. We're going to get back to that later. So, I thought she had nephritis. I'm going to ask you to guess which is most likely, class 1, 2, 3, 4, or 5. Is this on my thing here or not? Oh, it's not. They didn't turn this into a thing. Just raise your hand then. How many people think this is class 1? Good. How many people think it could be class 2? Membranoproliferative. I said, could it be? I'm raising my hand. It could be, but probably not. How many people think it could be class 3? It could be, but less likely than how many people think it could be class 4? Yeah, we all think it could be class 4. How many people think it could be class 5? Sure, it could be class 5. So I'm going to tell you something. This patient had a biopsy and there was nothing there. Okay, so let's go over what we expect to see on the biopsy with these different classes. Now, I got a lovely cross-sectional picture of the kidney for you here. And stuff comes in and stuff goes out, and hopefully in between, we filter all the bad humors out and retain as many of the good humors as possible. Now, as you enter the afferent arterioles, you get into the glomerulus, and right next to the glomerulus or right next to the afferent arterioles, you're going to find those blue cells, and those are mesangial cells. And so class 1 is some kind of minimal mesangial involvement. In class 2, you start to see proliferation of the mesangial cells. And you do have immune complex deposition. In class 3, we now move into the glomerulus, into these capillary loops down there in the middle there. A very convoluted network of capillaries, and where a lot of filtration takes place. And class 3, you get focal endocapillary deposition and proliferation, and you get subendothelial deposits. You get the same thing in class 4, except it's diffuse. In either class 3 or class 4, you may start to see a lot of chronicity, so we segment those into active and chronic, or chronic. When you get to chronic, you actually get to class 6 when everything's chronic, and that's sclerosis. And then class 5 sort of takes place at the subepithelial level, and that's where the immune deposits were. And you get a thickened basement membrane, and you get these immune deposits. So lupus nephritis, whether it's glomerulonephritis or class 5, is really typified by these deposits of these immune debris and inflammatory substances, which can become mostly in the proliferative nephritises of 3 and 4. You can get these crescents, and that's a really bad prognostic sign. And what you see in class 5 is you get effacement of the podocytes, and a lot of protein will spill out through the damaged podocytes. So that's what you get. And then, there's another thing you can get that's mostly seen in the glomerulonephritis, not so much in class 5, called tubulo-interstitial disease. It's really the same pathology. It often is typified by interferon alpha, and a lot of infiltrating T cells, B cells, and even myeloid cells, all acting very much like lupus right there in the interstitium. And that disease is a bad prognostic sign as well. So those are the things we expect to see in a biopsy, and they were not seen in this case. Now, I thought this patient had lupus nephritis, seemed to me. I guess you can get a biopsy where the sampling isn't showing you what you want to see because you're in the wrong, you got the wrong sample. But it turns out that this patient did have effacement of the podocyte foot processes. And so we're beginning to recognize an entity called lupus podocytopathy. It sort of resembles minimal change disease. It's possibly on the spectrum of class 5, but you're just not seeing immune deposits, and it's speculated that this is just infiltrating cells causing a direct damage from cellular activation. You do see effacement of podocyte foot processes, and it's generally associated with other evidence of severely active lupus, as this was. And again, no immune complex deposition seen on biopsy, but at least anecdotal evidence suggests that it may respond to immune suppression. Now, we're kind of stuck here, and I can't really make a recommendation, so I would everybody just call Brad Rovin, present your case, and ask him what to do. Because our evidence is really C evidence, and it's kind of anecdotal. But this thing seems to exist, and I would just make a notation to you, and it's not a recommendation, it's a notation, that calcineurin inhibitors may have a podocyte stabilizing effect. So they may be working two different ways, at least in class 5, and then as a speculation, perhaps in this disease as well, that they can help with the inflammation and they may and the immunity, and they may be able to also help just directly help stabilize and maintain the podocyte function. So I just want to point out, here's just another list of the classification for lupus nephritis that I just gave you, but I want to point out just at the bottom that even back in 2003, it was very strongly pointed out by the pathologists that we should also be thinking about whether there are microthrombi in the afferent arterioles and or in the capillaries, because that might be very important, and you might want to consider anticoagulation if there is. And then, of course, tubulointerstitial disease, which we mentioned before, is another thing that can happen. The tubules themselves actually can act a lot like macrophages, and they can start making type 1 interferons, spilling them out right there and causing a lot of inflammation. But this is a difficult entity as well, and I'm a little suspicious about it. It's seen mostly in proliferative nephritis. It is definitely a bad prognostic sign and suggests you need aggressive therapy unless there's a lot of fibrosis and it's too late. But in fact, the same pathology can be found from many, many things. Heavy metals can cause it. Obstructive uropathy can cause it. It can be seen with cancers. It can be seen with atherosclerotic kidney disease as a reactive process. You know, sometimes when you get myocardial infarction, there's a lot of inflammation going on, especially neutrophils. So, you know, a lot of stuff is happening in that kidney and we're not sure what's causing it. But most importantly, you know, some of the drugs that we use can cause interstitial nephritis. So our patients take antibiotics, our patients take diuretics, our patients take PPIs, our patients take NSAIDs, and then there's calcineurin inhibitors themselves, those podocyte modifiers that are very interesting as treatment for nephritis today, can cause tubular interstitial disease. So there you go. We're not 100% sure which came first, the chicken or the egg. When we see this, though, it's bad prognosis, and your best bet is probably to aggressively treat the initial nephritis to get that under control and then see what we can do. Now, by special request of Artie Kavanaugh, I'm going to mention some of these urinary markers. We're not there yet, guys, but it's a really intriguing field. I completely agree with him. I've given you a bunch of references there on the bottom right-hand corner, and I've listed for you some of the key players that are out there. This is something that you can get from a urine sample, and these are markers that, you know, there's now a growing literature that there can be associated with differentiating people with nephritis from people without nephritis, surveillance of nephritis, treatment responses to different treatments, and also prognostic markers for what happens later and how well or badly the patient does. You can see that VCAM1 is a very propitious one. There's 3 references, and it can be used both for surveillance and prognosis and damage. None of this is validated. None of these are going to be FDA-approved tests in the near future. It's just really kind of intriguing and on the horizon there. But there was an example at last year's ACR meeting of an early stage in the development of a panel. And here, 197 lupus patients, 75 of whom had active nephritis, were studied. And then there were 48 healthy controls. And they made a combination of those markers that I have in bold here. And that was their panel. You know, based on, you know, what seemed to be a good thing to test and put together as a panel. And so it turned out that that panel did predict active lupus nephritis. And then they added one more marker, AGP1, and it predicted response to Rituximab at 12 months. So that's the kind of work we need to be doing. I wanted to sort of comment on this. Any biomarker that we have, whether it's gene expression or, you know, soluble mediators or things we spill from the kidney, are going to be helpful in a number of different ways. So if you have a medication and you want to try to understand and build a set of biomarkers to help you be better doctors with that medication. It's not just about patient selection. It's also about, is there something that's going to change as a result of this medication that we can follow and even maybe adjust dosing and timing to optimize the change in that marker to where we see people who get better. So that's it. So following, it's really the surveillance issue. Will this go down if the patient's getting better? There's an awful lot of work to be done to figure that out, but it's really important. There's another subtlety here. What about the patients who come in with a marker and they don't get better? Maybe that marker didn't go down far enough, and that would be the answer. Or maybe there's something else going on as well. And here we have to get back to this notion of one drug isn't going to fit all. These patients are complex. We like to use drugs that we know what they're doing and not prednisone that does everything and has lots of side effects. But we may be able to do studies where using markers, we can say, well, look, I got that marker where it's supposed to be, and at that level, 60% of the patients got better. That's great. What's wrong with the other 40%? Maybe 20 didn't get down low enough. Let's give them more. Maybe 20% of those patients need something added on. And maybe if I study what's going on in them right now, I can choose wisely what my add-on therapy is. Because remember, all of our drugs that we're mixing and matching empirically today, unfortunately, both in rheumatoid arthritis and in lupus nephritis, have the potential to synergize with each other. That would be great. To be additive to each other, that would be okay. Or maybe to compete with each other. Or maybe to trigger off feedback loops in the immune system that we don't want because we went too far. So we don't really know what will happen, and our treatment remains largely empiric and is likely to stay so even as we begin to work with some of these more novel ways of diagnosing what's going on. I mean, that's the bad news, but the good news is maybe we have the technology to figure it out. So I think that's the hopeful point. Why is this important? Because the standardized mortality ratio for lupus goes up. If you compare patients with no renal disease to patients with renal disease, if you compare patients with no renal disease to patients with renal damage, and look what happens at end-stage kidney disease. That's the one out there on the right. And so our whole goal in treating lupus nephritis is to prevent damage. And the only way we're going to do that is to get the activity down as low as we can. And you know what? You know, we always fear dialysis because we know that's a bad prognostic thing. Patients live an average of 10 years unless they get a kidney transplant if they're on dialysis. But this is a really scary graph. It's this about chronic kidney disease in general, not just lupus nephritis. But this is a Kaiser Permanente study. It's pretty large. And so, you know, we're going from left to right. We're looking at more progressive kidney damage. And you can see that the people in purple are the event-free people, and the event-free people going down as the damage goes up. So bad things are going to happen to these people as the kidney damage is getting to a higher stage. And now look at dialysis. That's in green. Well, not so much dialysis at stage 2, not so much at stage 3, quite a bit at stage 4, but that's not the scary part. The scary part's what's in red. That's death. At every single stage, there is more death than there is dialysis. That's scary. So we would like to prevent damage in lupus nephritis. Which of the following is not a poor prognostic factor for lupus nephritis? Interstitial nephritis, anti-SSA Rho, a high chronicity index, meaning renal damage, or failure to take antimalarials? You've got to pick one. Which is not a poor prognostic, and by the way, it's a trick question and it's really not fair, but you got to pick one. Okay, so Most people picked anti-Rho, which is what I would have picked, and it's wrong. Some people picked failure to take antimalarials, and that was a reasonable one, and it's wrong. Everything's wrong, because all of those things are poor prognostic factors in lupus nephritis. So I gave you a lot of references, and anti-Rho, that's a little iffy. It's only one study, but it's there, it's on the list. So interstitial pathology, anti-Rho antibodies, renal damage pre-existing, and failure to take antimalarials are all poor prognostic factors for lupus nephritis, or at least have been cited as such in studies, to the extent that our literature is any good, and it's a little bit good and not perfect. But what's this about antimalarials? Why would antimalarials have a big impact on lupus nephritis? You've probably heard people whisper about this, because it's been around for a while. But one of the besides sort of stabilizing membranes and things, one of the things that antimalarials do is it interferes with toll-like receptors and actually decreases the manufacture of type 1 interferons. It occurred to us, because we had data, and so did a lot of other people, by the way, now, that the people with elevated bliss are the people with the type 1 interferon activity. That's who has elevated bliss. Whether there's a direct impact on the myeloid cells that make most of the bliss is possible, not 100% clear. There's some indirect evidence, but those are the people. If you have a subpopulation of your lupus patients with high interferon and you look at their bliss levels, their circulating bliss levels, you're going to find that they're higher than people who don't have that signal overall in the general population, with exceptions. So that's sort of, we said, well, maybe then we could show that hydroxychloroquine lowers bliss. Maybe it does. And it didn't. So here's 95 patients. And what you're looking at here is a tilde gene expression assay. We're looking at the expression for the gene that makes bliss. That's the blueprint for bliss. And if you see a positive, not a negative number there, it actually can be translated into, this is the fold difference, so that if you're on hydroxychloroquine, this is the number that refers to how much you decreased the bliss. Not too much, not statistically significant, not that big a deal, right? But then we said, wait, it's only the high interferon people who make all the bliss. Why don't we just look at that group? And that's who it was. So all of that was being, caused by the people in the high interferon group. It was half the patients. In adult lupus, it's usually about half the patients actually have a high interferon signal. It's higher in clinical trials because they only want sick patients to come in. But here they are, and the bliss was lowered quite a lot in the patients on hydroxychloroquine compared to those who are not on hydroxychloroquine, and this is not true in the interferon low group. So, not surprisingly, we got a pretty good result from the belimumab trials. I want to say one thing about the belimumab trial that's really important to understand, and that is that when you see the voclosporin results, you might go, well, the voclosporin was more dramatically better, there's a bigger difference between treatment and placebo than the belimumab trials. But I very much want to stress that you keep in mind that steroids only had to be tapered over 6 months in the belimumab trial. These patients got a lot more steroids, and therefore you should expect them to have a lot more high placebo response rate. And that will narrow the gap between treatment and placebo. What you might want to look at is a very consistent result that started early and was maintained throughout the trial. But I do want to say that if you look at the different subclasses of nephritis, belimumab did not have the same impact on class 5 nephritis that it did on the other classes of nephritis. So you want to keep that one in mind. Now, as I said before, calcineurin inhibitors, they inhibit T-cell function and sort of affect the IL-2 pathway. Also may affect proteinuria through non-immunologic stabilization of podocytes. So they're kind of interesting to us from class 5. And just to briefly remind you This drug has just been approved for lupus. It's one of the calcineurin inhibitors where there is some case in a preliminary way to be made that it may have fewer side effects than some of the other calcineurin inhibitors that we've been studying over the years and even using widely over the years. And they got very good results in their phase 3 trial. And now let's look at their class 5 results. So if you look over next to the last one, membranous pure class 5 nephritis, you'll see that there was a difference between treatment and placebo. It wasn't as good as in the proliferative nephritises, but if you look at the mixed picture, that looks pretty good. So if you've got mixed class 5 and proliferative nephritis, they got a pretty good result. So in summary, the prognosis in lupus nephritis is really important, and we have to think about signs of poor prognosis. Remember that we have to treat the immunologic disorder. We have to, over the next decade, come up with more rational ways of selecting and optimizing how we dose these patients and what drugs we mix together, and we have the technology to do it, and we must. But we have to also remember that some of the pathology that is even associated with poor prognosis may not be caused directly by the immunologic disorder, but by some of the drugs that we're giving. And don't, of course, forget infection, which I didn't cover, but you all know very well about in your lupus nephritis patients. So what we need to know is whether each potential treatment penetrates to the tissue, is necessary or sufficient for an individual patient, and interacts positively or negatively with other treatments.
All right. All right, thank you very much, Dr. Merrill. We have questions. Actually, one question is sort of general. When will the recorded lectures be available? And that'll be a couple of weeks. Here's a case, Dr. Merrill. I have a patient with class 5 nephritis on mycophenolate 3 grams, Plaquenil 400 milligrams, not responding. What would I do? What should I do next?
I would add a calcineurin inhibitor.
Okay. Straightforward answer. I like that. Okay. If you have lupus podocytopathy diagnosed on kidney biopsy, would you consider calcineurin inhibitor on its own or along with mycophenolate?
I would probably do both. It depends a little bit on the patient, but a lot of these patients have evidence of other severe lupus going on. So I tend to go to double therapy in sick patients. These are odd patients, but they have a tendency to be kind of sick. If the patient's not so sick, that might be a different story. Remember, people don't treat minimal change disease.
Okay. Over the front right microphone.
I have 2 questions. First, what is the role of vitamin D in active lupus nephritis, and what dose of vitamin D is recommended if the serum vitamin D level is normal in active lupus nephritis?
Well, I mean, do you start by doing it at vitamin D level?
So if the patient has normal vitamin D level,
I don't know if there's a case for that, is there? I mean, I might be ignorant and you may know more than me. What do you think?
I thought that there is some role of vitamin D supplementation in patients with active lupus nephritis.
I think that, first of all, there's a role for vitamin D deficiency in lots of aspects of lupus, including nephritis. But I'm not sure about if they have a normal vitamin D. Vitamin D is one of the fat-soluble vitamins, and you can overdose on it.
My second question was, I have 2 questions. The second question was, what are your recommendations about starting dose of mycophenolate in active lupus nephritis? Do you recommend starting at a lower dose and gradually titrating it to 2 to 3 grams, or do you start with a very high dose in active lupus nephritis?
If the patient's never seen it before, I would probably start as low as 2 grams in a person who's probably my size and maybe lower in a smaller person, and then work it up as fast as you can. You know, you might have to titrate a little bit just because of the diarrhea.
All right. Dr. Cush.
Joan, do you think calcineurin inhibitors have been around for a while? The lupus mavens and few of us actually have used them, either Tacrolimus or cyclosporin.
Back in the olden days, when I was young and you were middle-aged, We used to use cyclosporin, didn't you?
Yeah, but I still think not many people, I think it was just a few. I don't think it was many people that were using it. I think because you were bolder and you read the data and you knew how to monitor it and whatnot. But I want to know, has that experience from before helped inform the use of voclosporin now?
Well, I think what really set people off were these Chinese studies of tacrolimus, because they looked really good. Now, these were not perfectly conducted studies from the point of view, like the FDA wouldn't have liked them. Sometimes the assignments aren't randomized exactly, but they do have, some of them had groups, the comparator groups. And there's 3 or 4 studies now, and the one that, I remember some really dramatic data from those. And, their side effects that they were reporting weren't so terrible. Now, if they were using MMF, they tended to use only 2 grams. But that seems to work pretty well in an Asian population. I suspect it's size. I'm not really into race, and genetics, because our patients are too heterogeneous within races. So I don't believe in that stuff. But I think maybe it had to do with small size.
So there's a couple of questions on Rituximab in lupus nephritis. General question on Rituximab and lupus nephritis, should another study be done? And also, what about Rituximab following or followed by Benlysta?
Yeah, we've got spotty data from that, from different studies. But again, we all know the difficulty in lupus trials. What we have for Rituximab right now is a huge anecdotal literature. I think that there are many rheumatologists. Let's poll. How many people here have used Rituximab for lupus nephritis? So, I think, sure, I would love to see a study of Rituximab in a very controlled situation, done the way they just did the Obanitus Map Trial. So that's Genentech again. It's the same company, or Roche, same company. They have a different, it may be a little bit more of a B-cell depleter than Rituximab. But remember, they also had an Ocrelizumab trial that didn't do that great. But if you don't squint too hard, their data isn't that much better. It's just a little cleaner. So I kind of like to see all of these things studied the way they did Obanitus. And what they did was they tapered the steroids rapidly, which did not happen in the original Rituximab trials. So again, you've got these high placebo response rates.
Question?
Membranous neuropathy. Is there a difference between primary membranous neuropathy and that membranous neuropathy occurs with lupus? Is there a functional or histological difference? Thank you.
Don't think so.
Okay.
In lupus, you're going to have anti-DNA and you're going to have lupus, right? But in class 5 nephritis, you don't always have an anti-DNA. That was a shocker to me because I didn't learn that in the textbooks. I learned it in clinical practice.
There's a couple of questions on individual cases. Maybe you can discuss with Dr. Merrill. But one last question, which I'd really like to hear the answer. What is your take on the dosing of pulse steroids at the start of treatment? 500, 750, 1,000 for 1 or 2 or 3 days?
Yeah. When I was young, we used to blast them with 1 gram, and I learned that that's not necessary. So I actually think 500 maximal if you're going to do pulse steroids. It'll work.
For how many? For 3 days?
Yeah. Maybe, unless the patient refuses the 3rd dose, and they often do well,
All right. Well, thank you very much, Dr. Merrill.